So we'll walk through the real scenario that highlights critical decision making in the first few hours of burn care in the emergency department. So this is a 35-year-old male rescued after being trapped in a house fire for almost 60 minutes. He presents with burns to the face, neck, chest, and both the arms. His vitals are a heart rate of 122, RR of 28, a BP of 160, saturation of 92%, and he has a facial suit, if you could see, hoarseness in his voice and synced nasal hairs, classical signs of potential inhalational injury. So, looking at this case, what do you think can be an immediate concern? Can anyone enumerate, or can anyone just come up with some answers if you could?
Hi, sir. Is it you're thinking about the airway?
Yes, anything. So what? Yeah. So at this condition, what could be the airway? Expected answers could be airway. Yes. What else could be the immediate concern? Anything more than that?
His temperature, sir.
Okay. Yes. Temperature. Yes. The patient could be hypothermic. What else? Any other injury that could happen with burns, or that we can suspect? Okay, I'll just move ahead with this. So we should also think about something. The patient can go in shock. So a circulation can be a problem, a burn shock. And also one important thing that we should understand. So whenever there is a burn, a history of burn, and in an enclosed space or an enclosed area, we should always think about carbon monoxide poisoning. So that is also one of the very important things that we should think on. So in such a case, would you think you should go ahead with intubation or just wait? So we apply the ATLS primary survey, that is the ABCDE approach to burn patients too. But unlike trauma patients, burns can have a delayed deterioration, especially with airway edema and burn shock. So fluid resuscitation must begin early and be titrated. And also we shouldn't forget that frequently reassessment. In a case of a burn, reassessment is something which plays a very key and a vital role. Also, the urine output and perfusion needs to be checked again and again. So what are the three things that we need to reassess again and again is the vitals, the urine output, and the perfusion. So the ATLS approach is the same as that for burns. We follow the ABCD approach, which is the systematic approach to trauma assessment. Prevent the burn shock, which is the early fluid resuscitation, which is very, very critical. And we have to reassess. As I said, three important things that are vitals, urine output, and perfusion are to be reassessed continuously. And we have to apply for the burn center referral criteria and know when to transfer to the specialized burn center. That I'll tell you later. So the very first thing that we need to understand if we are near to it, so the very first thing is to stop the burning process, remove from the fire or the hot area, ensure scene safety is what we have learned in BLS as well. And cool burns, that is the room temperature. So whenever we see a burn, we have to avoid putting an ice on it because there can be a risk of hypothermia. As already the patient has burns, we should avoid using ice and use room temperature water for at least for 20 minutes. If the patient is wearing any clothes, we have to take them off. Also jewelry, we have to take them off as it will prevent constriction as the swelling occurs. And cover with warm or dry linen. Maintain the body temperature. So that basically maintains your body temperature and protect the wound. So going forward, in this patient, the airway is clearly at the risk. As we have the red flags, as I mentioned, the patient had soot, hoarseness, signed nasal hairs, and stridor. Signed nasal hairs is basically the burned hairs that you can see, and the soot is basically something of a black substance which are basically inhaled, or it could be seen inside the mouth cavity as well. So if something of that has been seen, there is a high possibility that this patient might develop an edema later. So ideally, an intubation should be progressed quickly in such a case, and you have to go ahead with a intubation ETT of 7 millimeters. That would be more than important because the secretions and bronchoscopy, if need to be performed, the bronchoscopy tubes that we have would easily fit in a 7 millimeter endotracheal tube. So that is the reason. And in cases of a pediatric, 4.5 is what has been suggested. And airway intubation, in such a case, we always have to think that always have to be intubated by an experienced provider, and it is very, very important to do so. And early intubation in such a case where you have three signs like a soot around mouth and nose, hoarseness of voice, and signed nasal hair, you should always move ahead with intubation and do not delay it. Because if we delay it and if an edema sets in, it would be very difficult for us to go ahead with an airway intubation. So in breathing per se, breathing concerns three important things again. One important thing is the hypoxia. The second is the carbon monoxide poisoning. The third is smoke inhalation, as I told you before. So going ahead, when I was working back in MGM Hospital, Vashi, a few days before, there was a mass casualty in my emergency department where I had approximately 28 patients coming to the emergency room. But it was due to something else. So it was due to something because of an AC vent which was put inside a factory, and they just put it on, not an AC vent, a generator, and they just put it on and it was going off, and it runs through petrol. So when the fumes went inside the room, what happened was the patient started fainting over there. So almost out of 26 or 27 patients, 10 to 15 patients fainted off. And when they came to the emergency department, they were in confused lethargic states. And when we did an ABG, we got to know that the patient was having carbon monoxide positive for such patients. And in such a case, you should remember carbon monoxide in cases of burns as well is very, very important. Also, in this case, you have to suspect cyanide only when your GCS is less than 10. The patient is having hypotension and is having metabolic acidosis, which is unexplained by other causes. This is a very, very important thing. And if you suspect cyanide, and you have to have an antidote, which is hydroxycobalamin, which is given over a dose of 5 grams over 15 minutes. So in such a case, ABG and carboxyhemoglobin levels, which is more than 10% levels, which is very, very worrisome. And you should remember that it is very, very dangerous. So oxygen therapy in such a case is important. We have to go ahead with 100% oxygen for such patients. And also do a chest X-ray to establish a baseline of whatever is going on. After that, while coming to circulation, the very, very important part is as we go ahead in ATLS, we secure large IV bore cannulas, and we go ahead with the ringer lactate solutions. So a lot of my students or my residents had a question saying that why should we only use ringer lactate solution and why not normal saline in this case, and why not some other fluid in this case, and why ATLS is preferring more over ringer lactate solution. So the main thing about ringer lactate solution is that it has got what do you say? A ringer lactate solution is something where you have the constituents of ringer lactate is almost equal to that of the plasma. And with a normal saline, you have more of chloride in it. So the chances of acidosis in that case is really, really high. Hyperchloremic acidosis is really, really high. So that is the reason. Yes, anyone had to say something? Okay. So the ringer lactate solution that is the reason it is much preferred. So previously, as we said, we used to go ahead with the Parkland's formula. But now in the ATLS updated guidelines, they have said that you shouldn't be very stringent with the Parkland's formula, which used to be 4 ml into the body surface area into the body weight, as they said, and it is to be given over 8 hours and 16 hours. So what they said was, if we give 4 ml per 4 ml into the percentage of body weight into the body weight, whatever the fluid calculation used to come, it can go very, very high for a person and the patient can land up in pulmonary edema. So what they have come up with is in adults specifically, they have mentioned that you should go ahead with 2 ml per kg per hour. In a pediatric less than 13 years, we have to go ahead with 3 ml per kg per hour. And for a patient with electrical burns, both in adults and in pediatric bachus, we have to go ahead with 4 ml per kg per hour. But then the calculation, whatever it is, I'll tell you on the later half. But then this calculation is only to be done when you reach secondary survey, where you calculate the total body surface area. So in the primary survey, what ATLS guidelines say that you should go ahead with starting on with a fluid ringer lactate with 500 ml. You'll have to just start it. You just start 500 ml ringer lactate solution, and in cases of pediatrics, you have to start on with 250 ml fluid. And then when you reach the secondary survey and calculate the total body surface area, that is when you'll have to apply the formulas as I mentioned. For adults, it is 2 ml per kg per hour. For pediatrics, it is less than 13 years is 3 ml per kg per hour. And for the electrical burns, it is 4 ml per kg per hour for both adults and pediatrics. So warm fluids is what prevents shock, and you have to maintain normothermia and monitor vital signs as heart rate, BP, capillary refill time, and urine output. Urine output is very, very important. So we have to monitor urine output continuously, hourly basis. For adults, it is 0.5 ml per hour, 0.5 ml kg per hour, and for pediatrics, it is 1 ml per kg per hour for less than 13 years of age. So start 2 large IV bore cannula, start an ringer lactate solution, insert Foley's catheter. So any patient who's receiving a burn resuscitation, you should always remember you have to insert Foley's catheter for such a patient. And you should have a set target of 0.5 ml per kg per hour for adults and 1 ml per kg per hour for pediatrics. And also remember one important part, that you have to avoid boluses unless the patient is hypotensive. So if we don't have an hypotensive patient, if the patient is in shock because of burns, you should go ahead with boluses. But if the patient is not in shock, you should definitely go ahead with a normal fluid resuscitation, as I mentioned. So coming to the disability and exposure, you have to do a full neurological assessment as GCS, pupils, the motor response, fully expose the patient to assess the burn extent, but protect the patient against hypothermia. So as correctly said by one of the students previously, that you should look on for hypothermia. Hypothermia is very, very important. You have to use some warming blankets, and there's a device called as Bear Hugger device. You can use those and use warm IV fluids. And one important pro tip, any patient that is coming with burns, you should always remove the jewelry as early as possible, because this swelling can lead to constrictive injuries. So constrictive injuries could be very, very fatal and very, very dangerous later on. I would come back to, I'll come on this for the later slides. So now, a lot of residents do ask me this question: do we go ahead with popping this blebs or popping those blisters off? So as they say that I like it, but then blisters, if they are very small and if they are on the joint specifically, so if they are very, very small, you have to avoid breaking it off. And if they are on the joint specifically, and if they are hampering in measuring your total body surface area, that is when you have to pop them out. Otherwise, there is you shouldn't pop them out. But the evidence based on popping and non-popping of blebs is still very controversial. Some guidelines say that we should go ahead with it. Some say they are against it. So it is a very, very controversial statement over there. So coming to this is some important part that we need to focus on, is the layers where you should be focusing on. So this is a zone of coagulation, if you could see in the center. And there is zone of stasis in the second half. And the third half is where you could see your zone of hyperemia. So the coagulation zone is a zone where if the burn reaches over there in the coagulation zone, it is irreversible necrosis. So once burn reaches there, it is impossible to save it or salvageable. It is not salvageable at all. So when you reach, if the burn reaches a zone of stasis, it is an area of low perfusion, but potentially salvageable. And there is a zone of hyperemia, which leads to vasodilation and leads to inflammation. That is the reason it is most of the times we can see it as red. So when we give fluid resuscitation is always in the cases of zone of stasis. So zone of stasis is where we are actually focusing on. That is where the resuscitation fluid or ringer lactate solution will actually act on. So yeah, so this is what I wanted to tell. Zone of hyperemia is the tissue perfusion is increased. Zone of stasis is where the characterized by decreased tissue perfusion and can be salvageable. So that this is where our resuscitation techniques would come into action. So in pathophysiology, if you could see if there is any burns per se, what happens is there is a release of a lot of mast cells. So if you could see, just a moment. Yeah. So if you could see, there would be a lot of release of mast cells, which releases pro-inflammatory cytokines, and that will lead to increase in the vascular permeability. So first degree and second degree burns are basically burns which are very, very painful because your nerve endings probably are not been involved over there. From the second degree, full thickness burns and third degree burns is where your nerve endings are totally been involved, and that is where your pain totally goes away. So now, when the mast cells have been released because of the burns, and there is pro-inflammatory cytokines been released, what happens is the vascular permeability is increased, and there is basically, and the fluid would start shifting out from the extravascular area. It start going into the interstitial area. So this happens, and also it leads to blister formation. While in cases of deep burns, what happens in deep burns is the blood vessels and the nerve endings totally have been destroyed. So what happens is you have a not dry and non-blanching area, and it is dry and inelastic. In the same case here also the same thing happens is the vascular permeability is increased and the fluid is shifted from the intravascular space to the interstitium, and that leads to hypotension. Also, the nerve fibers over here, the nociceptors are been damaged. So that is the reason you get hypoesthesia. So that is an important diagram which would actually tell you what exactly is a problem here. So this is a major investment. I won't go into details, but more than 30% of the burns, if any burn which is exceeding more than 30% of the burns, this would lead to cardiovascular dysfunction and might land up in sepsis or multi-organ failure. So there is a lot of things which goes on is hypovolemic shock, liver dysfunction, changes in the electrolyte balance, immune inflammatory dysregulation, and a lot of other things. So if you look at the burn, so how do we recognize is there an epidermal or Nikolsky's kind positive? If you just put a finger on your burns and if it slips, then yes, if it is an epidermal thing. If it doesn't slip, then run a gloved finger over the burn. And if it is slippery, then you have to see for which type of blister it is. If it is
Dr. Alok, so I just got a message from people that the screen is not clear, but I mean, it is clear to me. Maybe you can just remove that enhance for video thing you have selected, right?
I don't think so. I have animation you said, or what exactly?
No. The screen clarity is not great. That's what
Okay.
everyone feels. So this while sharing the screen or somewhere you have selected enhance for video.
Yes.
So yeah, just optimize for video. Yeah, plus just remove that. Okay.
Okay, I did that.
Yeah.
Just have a look if it is normal now. Just a moment. Just see if the video is normal now.
Okay. I think this is better, right? I mean, uh, Yeah, this is better.
This is better?
Yeah, please go ahead.
Okay. Yeah. So yes. So we have to run a gloved finger over the burn, and if it is slippery, then we have to assess for the type of blister. If it is a thin wall or popped, it is a superficial dermal, and if the type of blister is thick walled, it is basically mid dermal. And if it is not slippery, we have to see for the burn color. If the burn color is red, it is deep dermal, and if the burn color is white, it is basically a full thickness. So that is how you basically go ahead with the assessment of the burns. So in secondary survey, the very important thing what we should do is we have to gather additional history, head-to-toe examination, the total body surface area, and minimum to minimum what you have to do is we have to at least extract the ample history, and you have to put special attention to the mechanism, the duration, the circumstances, and the time of injury. This is very important. And also remember a very pro tip that you shouldn't be counting the superficial burns into the total body surface area. It has not been counted. Uh, so we have a few things with the ATLS that they have come up with. As I mentioned, the formulas have changed. Like we used to use the Parkland formula, and previously I mentioned about the adult. What we can do is we can use 2 ml of ringer lactate solution into the body weight kg and the percentage of total body surface area. So now they have come up with something which, if you could see and if you could visualize, they have divided it by 16. So what exactly is that? So I'll just give you an example of what exactly that is. So suppose if a patient is there of 80 kg with a 40% total body surface area involved. So he's an adult. So we'll go ahead with 2 ml per kg per hour. That would be 2 into 80 into 40. That would be giving us 6,400 ml of ringer lactate solution. That has to be given over 24 hours. We have to remember this is a solution which is to be given over 24 hours. But now, as I mentioned in the primary survey, we started on with a ringer lactate solution of 500 ml, right? And I mentioned specifically in the primary survey that once we calculate the total body surface area in the secondary survey is when we would apply this formula of 2 ml per kg per hour for adults, 3 ml per kg per hour for pediatrics, and if it is an electrical burn, we have to go ahead with 4 ml per kg per hour. So now in this case, where the total fluid has been calculated as 6,400 ml of ringer lactate solution for 24 hours, now we have to divide it by 16. So now divided by 16. So now whatever we have got is 400 ml per hour. So this is what we have to start on with an hourly basis for this patient. So in such a case, we have to start on with 400 ml of solution per hour, right? And we also have to see. So some of the residents also ask me this question: if we go ahead with 400 ml solution and we calculate it over 24 hours, it might come up to 9,600 ml. So do we give that much of fluid for the patient? So no, it is not like that. So if we give 400 ml per hour, we have to monitor the urine output for the patient. So for adults, as I mentioned, 0.5 ml per kg per hour is what is a target that we need to achieve. So if supposition 400 ml I have started for this patient an hourly basis, and the urine output is coming out to be 0.3 or 0.4 ml per kg per hour, which is not reaching up to the expectation of 0.5. So what I'll do is I'll add 10 to 30% of more fluid to the present fluid. So instead of 400 ml, I might give 500 to 550 ml of ringer lactate solution and monitor for his urine output again until it reaches 0.5 ml per kg per hour. So that is how I understand that the fluid resuscitation is going normal. Again, there's one more resident who came up with a question saying, why only 16? Why did they divide 16? Why not 18? Why not 20? Why not 14? Why not 12? So even I was very baffled by this question, and I went back and studied about it. So what I got to know with their logic was, so if we take 18 ml or 20 ml per se, what happens is the fluid concentration would drastically raise. And once we give more fluid concentrations, the chances of the patient going into failure is more when we use something of a higher calculation. And if we decrease it, the fluid, whatever, say 14 or 12, the adequate amount of fluid has not been delivered. So that is the reason they came up with something which is 16, which fits in their criteria pretty well. Okay, so rule of 9, I think a lot of people would know about it, the rule of 9. I won't go in details about it. So rule of 9 is what has to be calculated, and rule of 9 is for the adults. But if we want a proper estimation is only by the Lund and broader classification. That is where we will get a proper classification of burns. And there is also which is called as a hand rule. Hand rule in cases of very small burns, where if the burn is just occupying your hand, it is just 1% of it. So yeah. So accessing the depth of burn, as I mentioned previously, it is the same slide. So now an hourly monitoring, as I mentioned previously, in the starting, we have to go ahead with the primary survey. We'll have to go ahead with a 500 ml solution, and till we reach the secondary survey. Secondary survey, as we reach, we have to calculate 2 ml, 3 ml, or 4 ml in electrical burns, assess the urine output for the patient, and monitor the patient. Keep on monitoring continuously. If the patient is not reaching the 0.5 ml barrier, probably you might have to increase your fluid resuscitation. And if the patient is reaching up and above 1 ml per kg per hour, you have to decrease it by 10%. And that is how you have to go ahead and maintain an urine output and the fluid resuscitation for this patient. So yes, coming to the next part of it, which is the compartment syndrome and the escharotomy. So this is a very, very important half. Just a moment, I'll just have a sip of water. Yeah. So now, when do you actually go ahead and go ahead with escharotomy? Is when there's a small mnemonic which sounds a bit weird, but then it has longitudinal incisions, axial planes, and into the normal skin, and you have to go ahead till the subcutaneous fat. You have to remember, you shouldn't be going ahead till the deep fascia or the muscles. Yeah, you only have to go ahead with deep fascia and muscles when there is an electrical burn in place. Because whenever there is an electrical burn in place, what happens is the compartment, basically your muscle fascia has been involved. That is when you have to go ahead with a muscle fasciotomy. So now, in this case, you can actually see we have put in a lot of anterior axillary incisions. Proper incisions have been taken to relieve the compressions, to relieve the compartments of them. So when do you suspect? So now this is very, very important. When do you suspect? Especially, as I mentioned previously, if there was any jewelry or there was any cloth, so that might lead to circumferential limb, which is basically constricting injuries or constricting burns, right? So there are 6 P's that you should remember, which is pain out of proportion. There is pallor, there is pulselessness, paresthesia, paralysis, or pressure, right? So escharotomy is to be performed. This is basically a clinical diagnosis where you should understand that the patient is having a compartment syndrome, and again focusing and again saying you very, very thoroughly that we have to only go through down to the subcutaneous fat and not go until the fascias or the muscle. Only go to the muscle when we are suspecting an electrical burn. Yeah, so these are the incisions basically. These are the incisions where you have to ideally put an incision for the patient. Now, wherever you're suspecting an ischar has been formed and the compartment has been raised, that is how you should go ahead with. So the pain. So you don't have to start with the opioids until airway and circulation are been addressed. You have to remember this. So address the priority first. The priority is fix the hypoxia and hypovolemia before the pain management. Use IV opioids titrated to response. So again, which IV opioids to be used? Ideally, we have the use of fentanyl at a dose of 0.5 to 1 micrograms per kg, or we have morphine for that matter. And sedation to be used is basically midazolam can be used, or we can use ketamine at times for pain management or sedation. But also in terms of midazolam, you have to also see for hypotension. If there's hypotension, that you shouldn't be using midazolam. And with ketamine, you should remember it might lead to hypertension for that matter. So if the patient is hypertensive, you should always be taking care of. Dexmedetomidine is also been preferred, but then the action is quite slow. So it has not been quite been studied well in the emergency settings. So the wound coverage, what we can do is cover the wound with a non-sticky dressing. And a lot of times what we can do is we can irrigate, as I mentioned, hypothermia is a case. Hypothermia is a thing with burns. So we can use normal room temperature water to clean the burns for 20 minutes. And what we can do is if we want to refer the patient out, referred only when the burns is more than 10%. Yep, we can refer those patients out, and we have to, if we don't have any sterile dressing available with us, what we can do is we can put the hand in a sterile plastic and then close it off, and then we can send the patient up ahead. So in preventive care, we should confirm the tetanus status, and we have to update the tetanus if need be. So now, so there's one more thing. So when do you refer the patient? So as I mentioned, total body surface area more than 10%. It involves your face, it involves your hands, your genitalia, and your major joints. If this has been involved, you have to refer it to the burn center. Also refer to the burn center when the patient is having an electrical burn, probable chemical burn, or an inhalational burn. Yeah. Inhalational burn, if you suspect this patient can be, can go bad, you have to intubate the patient previously. As I previously mentioned, signs of inhalational injury like signed hair or soot in the mouth or in the nose, anything of that sort, if you see, and signs of inhalational injury, hoarseness of voice or anything of that sort, you have to intubate the patient and then probably refer the patient out to the burn center. Also, there's one important thing. If the patient is comorbid and very young or old patient, in such a case also you should consider referring the patient to the burn center. Yeah, so this is the slide about the same thing. So this is a comparison which was given in the ATLS between the pediatric and the adult. The fluid formula, as I previously mentioned, adult 2 ml per kg per percentage of total body surface area. And in pediatric specifically, if you could see, they have mentioned about one important thing, that they have been added your D5 to it as a maintenance fluid. So again, to clear it off to you guys, like the children's are basically, they have very limited glycogen stores and they have a very immature liver. So in stress, in a stress situation, what happens is the risk of hypoglycemia is very, very high. So that is the reason we need to add the D5 solutions to it. So in pediatric patients, we have to go ahead with the 3 ml per kg per percentage of total body surface area of RL along with a maintenance fluid of D5. Yeah, but also remember, you don't have to mix those solutions together, right? D5 and LR together, no. You have to apply it differently. So in cases of pediatrics, the dehydration can go really, really bad, and the airway in case of a pediatric is very, very narrower, so they can go bad really early. So we need to estimate the percentage of burn area very, very accurately in cases of pediatric. That is the reason the chart that we have to use in a pediatric patients is lung broader chart, and in adults it is rule of nines. Yeah. So hypothermia risk in a pediatric is also high, and in adult it is moderate. And the ET tube, as I mentioned previously as well, in adults it is more than 7 millimeters, and in pediatric it is more than 4.5 millimeters. It's because of the secretions, and also the bronchoscopy would be easier with these tubes. And Yeah, so the case outcome, what the patient was intubated with a 7.5 millimeters AT tube because we need to go ahead. He had a signed hair. He had what do you say? He had a lot of other factors like what do you say? Signed hair. He had soot in his mouth. Yeah, soot near to his mouth, his nose. So signs of inhalational injury. He had hoarseness of voice. So that is the reason we thought of intubating such a patient and secured the airway before an edema would develop. Yeah, the fluid management. As I mentioned, the fluid management would be 500 ml of ringer lactate solution previously, and as we reach the secondary survey, the total body surface area would be calculated, and then in our patient, the 2 ml per kg per hour would be started. It would be divided by 16, and then per hour basis, we'll have to start that. And we have to monitor it accordingly with the urine output, right? So if it is less than 0.5 ml per kg per hour, probably we might increase our fluid to 10 to 20%. And if it is reaching up and above 1 ml per kg per hour, we'll decrease it by 10 to 15%. Yeah. And surgical intervention, what we preferred was ischorotomy done for chest burns. And as I mentioned, 6 P's, that is pain out of proportion, pallor, pulselessness, paresthesia, paralysis, and pressure. Yeah. So we have this 6 P's. We have to go ahead with ischorotomies. And I also mentioned about the lines where we have to properly put an incision for such patients. Yeah. Okay. So this is what I was mentioning, like how we can send the patient with a plastic bag. It has to be sterile. ऐसे ही कोई plastic bag, random plastic bags, you don't, unsterile, something of that sort, you shouldn't be using. So now there are two dressing types. One is an open method and one is a closed method. So in an open method, you leave it exposed. Just put an ointment, that is silver sulfadiazine cream or Mebo. So silver sulfadiazine is not to be used on the face. Mebo is to be used on the face, right? Mebo is used for the face and limb burns, and the limb should be elevated to reduce edema. And silver sulfadiazine is for pseudomonas and not to apply on the face, yeah, because it is very, very irritant. Be careful for silver allergy, as they will lose their skin. In open method, the burn is cleansed with antiseptic solutions, covered with silver sulfadiazine cream, which is an antibacterial, non-adherent layer of gauze, absorbent layer of cotton wool. On each dressing change, remove any loose tissue. Always use closed dressing except for face, hand, and perineum. So, burn complications, what can occur is infection, which is the most serious complication, which can lead to pneumonia as well. GI complications, curling ulcer is something which occurs in 12% of all the burn patients, which is prevented by prophylactic antacids or H2 blockers. Respiratory complication is a major cause of death in burn patients. Hyperkalemia can set in the first 24 hours because the destruction of RBCs, right? In the second day, there will be hypokalemia due to potassium loss in the urine. Suppurative thrombophlebitis, yeah, this is can occur change in IV position in the first 24 hours. Circumferential burn is relieved by ischorotomy. Circumferential burn, as I mentioned, by the cloths or by the jewelry that we have to remove, right? Because otherwise it might lead to something which will lead to a compartment syndrome. And that will be very, very disastrous, as we have to go ahead with ischorotomy. Can lead to cataract, and late complications can have dyspigmentation, bone contractures, hyperpigmentation, or hypertrophic scars or keloid. So the key takeaways and the references is basically from the ATLS, which is an ABCDE foundation. The fire or the thermal burns often involve the inhalational injury. We have to start the fluids early and titrate it accordingly. Monitor for complications, which is compartment syndrome or shock. Compare always the adult and the pediatric fluid therapies properly. So I was very, very keen for the antibiotic policy. I wasn't able to find it in ATLS, but ATLS has specifically specifically said that antibiotics should not be used prophylactically. Antibiotics is to be used only when you're suspecting an infection, and TT ideally should be used. So there was an update. I just went through the up to date, and up to date had to mention this, So whenever the burn wound is suspicion for infection, rapid change in the appearance of the wound or erythema or discoloration or suppuration or purulence or pus, if anything of that sort is present and the temperature is there, tachycardia, signs of hypotension, shock, so we have to go ahead with empirical antimicrobial therapy, and the burn wound debridement has to be done. The histopathology report, culture sensitivity report has to be sent, and if it is more than 10.5 per organisms of the tissue, an invasive wound infection, you have to consider with the systemic antimicrobial or wide local excision debridement at 24 to 48 hours for any necrotic or infected tissue. And same, if there is none of this, like no shock or no hypotension, tachycardia, we have to go ahead with the wound culture. And if the wound culture comes positive for more than 10 raised to 5 organisms per gram of tissue, you have to go ahead with a burn wound biopsy. But ideally, this won't come in the emergency setting, probably. I have just given it to understand and have an understanding of what exactly goes ahead in the further treatment of it, right? So in such a case, if such a thing happens, and if it doesn't happen, you have to, it is basically a non-invasive burn or wound infection, and topical antimicrobials is to be given for such patients, right? So if you're feeling burnt out by this presentation as of now, don't worry, at least now you know how to treat it. And I hope this presentation made sense with whatever I had mentioned and whatever I had to summarize in short in this half-an-hour period. I think this is what it is about the thermal burns and the ATLS guidelines and the latest updates with the thermal burns. Thank you so much.
Thank you, Dr. Alok. So you have navigated this topic really well, and the calculations and all were again explained by you multiple times, and I feel that's really well done. Really appreciate your efforts for getting all the AI generated images. Also, you have used all the prompts and generated the images for this particular PPT. So really appreciate your efforts.
Thank
So
you so much.
we'll take, yeah, thank you, sir. So we'll take some questions.
Yes, please.
If somebody has any question, they can just post in the chat or just they can ask.
Where's the chat box?
So this there were studies I have just so yeah, somebody asking about role of steroids.
Sorry, hello?
Role of steroids. Somebody is asking about what is the role of steroids in burns.
Okay, I think the role of steroids in burns is specifically not properly been studied as per se, but I think in my what do you say, in my experience per se, it has not been routinely recommended in thermal burns because it suppresses the immune response and delays the wound healing. In such a case where you have burns, it will increase the risk of infection. So, but studies also have said that it is a very controversial role in cases of an inhalational injury. It may reduce the airway edema, but there's a risk of an superadded infection, which often outweighs the benefit. So the only thing where I think it is an autoimmune blistering or keloid or hypertrophic scar is where I think probably there is a role of steroid. But in cases of burns where thermal burns have been considered, I don't think it should be used.
Yeah, there's no basic general consensus about use of steroids in early burns, at least. So, and there's the next question is role of silver emergency blankets in pre-hospital. Those are actually space blankets which you're talking about, Anju. So these space blankets are actually used to prevent hypothermia in patients. So
Right. And ideally, it is only when it is more than 20% of your total body surface area has been involved is when
yeah,
ideally use it.
yeah. Right, sir. Right. So I have also posted something about because we get a lot of these cases, and usually the silver sulfadiazine cream is very expensive. Now these days we are getting silver colloid cream. So these creams are very expensive. So there have been multiple studies I have referred to which say that honey is in fact much beneficial and helps in faster healing of the wound compared to silver. I mean they are really published in PubMed.
Oh, great.
PubMed, I've shared two links just in the chat. So one of them says that the infection for honey is much lesser than the
Oh,
silver cream, and the next one says the healing time is also lesser. So we don't know, but we just continue to use silver, and maybe for low income settings, I mean low cost settings, we can use sofromycin also, which is also a good replacement for this silver cream. So that's what I wanted to add.
right. Great.
Okay, so if anyone else have any, this question is already answered. Will IV or inhaled steroid be used in airway edema? So yeah, sir has already answered that question. So if any other questions, we'll take it, and otherwise we'll call it a day. So okay, sir. Thank you very much. We'll we'll get back to you on next session. So in future, I hope you'll come back on Core EM again. So next session we are having by Dr. Kushal Pandya. So it is about management of carbon monoxide inhalational poisoning. So we'll see you next weekend, Saturday, 6:30 p.m. Thank you very much. Have a great day.